Greetings, everyone. Welcome to our Honorable Chair, distinguished guest speakers, and participants for joining the webinar session on challenges in innovation and design of healthcare using ICT. I would like to express my gratitude to SPIDER for making this happen. Before we begin, we would like to introduce our chair and guest speakers today. I am Zaki Haider. I'm the Director of Innovation at mPower Social Enterprises, and I will help moderate this session. To my left, Professor Dr. Be-Nazir Ahmed, former Director of Disease Control, Directorial General of Health Service, Ministry of Health and Family Welfare, Bangladesh. He has also led the Support and Coordination Center of Directorate General of Health Service, Ministry of Health and Family Welfare, Bangladesh, which is a hub for coordinating the innovative health initiatives in public health sector of Bangladesh. With us, we also have today Professor Dr. Alain Labrique, Director of Johns Hopkins University Global mHealth Initiative, as a keynote speaker. Dr. Labrique is a globally recognized leader in application of ICTs to strengthen health systems in resource-limited settings. To my right, we have Dr. Farzana Taher Munmun, Deputy Program Manager, Community-Based Healthcare for CBHC, Directorate General of Health Service, Ministry of Health and Family Welfare, Bangladesh. She is currently leading the largest mHealth solution design, development, and deployment project under CBHC. We also have third right, Dr. Rezaur Rahman Khan, Deputy Program Manager, Extended Program for Immunization, Director General of Health Service. Director of Support and Coordination Center, Director General of Health and Ministry of Health and Family Welfare. To begin with Dr. Be-Nazir Ahmed, so I would request, before I go to request Dr. Be-Nazir Ahmed to start this session, I would also like to say the webinar initiative is taken under SPIDER Health and Wellbeing Network, Swedish program for ICT in developing region, or SPIDER. It's an independent public center with innovative programs in Africa, Asia, and Latin America. mPower Social Enterprises, my organization, is a social enterprise which is moving development paradigm into information age. The network was established in April 2017. That is to enable SPIDER's digital health program partners to share experiences and resources to enable greater cross-pollination of ideas. The goal is also to make use of digital tools, knowledge, and research within and outside the network to enable individual member organizations to make their own projects and organizations more efficient and effective. So we are adhering to the digital principles for development and contributing to the UN Sustainable Development Goals. The expected outcome of the initiative is to adapt ICT to enhance access to information and services, improve networking and collaboration, use of health data for decision, these three. So now I would like to request Professor Dr. Be-Nazir Ahmed to start the session.
Thank you, Jackie. I welcome all the participants who have joined with this session. Actually, we are happy that this has been arranged, and we would like to share our experiences, how we started ICT in healthcare services of Bangladesh, and what are the challenges we have faced, and where we are now. Actually, in some areas, we have achieved so much that really we are proud of that, and that is contributing in improving health in general of our people, along with social inclusion, leaving no one behind, addressing the poorest section of the rural areas, and also introduction of relatively newer technologies in providing health. So I think when we started, it was mainly for management information system in health, like collecting data on some of the actually uh, parameters relevant to health. But gradually it is scaled up, and now we have a very robust system. You can imagine that we have been connected to about 15,000 rural communities with internet, with a laptop, to the lowest actually service care provider. We call them community health care provider, and they are entering data every day. And also gradually we are actually moving to electronic data system. In all the health initiative, you can say different elimination prevention program, and also supervision and monitoring. We are connected with our health managers, about 64 at the district level, 500 at the sub-district level, about 40 medical college hospitals. So, and also there has been actually good collaboration among different sectors who are working with ICT in Bangladesh. And not only that, we are actually nowadays providing support to build capacity in ICT on health in neighboring. Our experts are going there, and also they are coming here for learning, for training. So with this background, we are happy that there has been some interest in the African region, and we will actually like to share our experiences, how we came here and how they can start. So thank you very much for starting this.
So to begin, sir, if you would like to shed some light on the coordination cells that have been established in Bangladesh, like how it helped eliminate duplication of different services by the government, and also how it is reducing different kinds of cost by sharing this training costs and that kind of thing.
Thank you, Jackie. Actually, it is the idea of Professor Abul Kalam Azad, the present Director General of Health Services of Bangladesh. And we have to mention that he is actually also the pioneer or the master or the maestro, you can say, about the e-health in Bangladesh. He was director of MIS for long 9 years, but even when he is DG, he has been contributing a lot. So he thought that when he became the DG, that actually in a poor resource setting, we should use the resources at the best, maximizing its utilization. And we actually found some incoordination and gaps in different government organizations, different directors within the ministry, and also different development partners who are contributing in health. So he actually established the Coordination and Support Center. Later, we were involved in innovation also, and actually I was the head of this center for long 2.5 years. Recently, I actually took another assignment, but still I am involved to some extent here. And during the last 2.5 years, it has actually done tremendous job in improving coordination among different partners. And also, actually, we are coordinating the e-health in Bangladesh so that we can have a actually common platform. We can use a common system actually that is applicable to all and not duplicating. Even we arrange a lot of coordination meeting among different partners. I think mPower was also involved to some extent in some of our projects. And also we actually try to develop and introduce different apps in our health system, and also application of ICT. Say, for example, in our HRIS, Health Resource Information System, we have been gradually moving towards paperless system, application, transfer, posting, and all other activities. So coordination center actually even was introduced in drafting some act, in drafting some policy, strategy, guideline, and overall to have a better functioning DG Health. And I think uh, that has been instrumental in actually strengthening different capacity, including ICT in health.
Thank you so much, sir. We would like this moment to take into notice that there have been almost 120 people who have registered to this webinar that is being broadcasted live right now. We have people from around 17 countries who are joining us today. I would like to give a shout out to these countries. We have Rwanda, Zambia, Zimbabwe, Ukraine, Kenya, Uganda, UK, Denmark, USA, Canada. We have people from Korea, Australia, Ethiopia, Tanzania, South Africa, India, and of course, Bangladesh. So a big shout out to all these different countries from where all these participants are joining today with us. And I would actually like to request Alan to provide some of the links and tools that he has shown with the audiences later on. So what we can do is we will add it in our website, and anyone who is coming to the website later on, listening to the videos that are being recorded, they can access those tools and links. And we'll also ask different all the participants who are connecting with us right now that you can ask questions for our different speakers, and we would like to answer to those questions as the best of our knowledge. So the way Alec was explaining that the solutions need to be thoughtful and well properly budgeted, large-scale interventions. So one of those large-scale interventions in Bangladesh is CBHC, community-based healthcare. And I would like to ask Dr. Farzana Taher Munmun to talk a little bit about that. Dr. Munmun.
Thank you, Mr. Zaki. I, Dr. Munmun, presently represents the community-based healthcare, and recently I'm working with a solution like mHealth solution, and we are working in individual health record system. My previous speaker said that our last primary health care is community clinic, and our community health care providers are collecting the service-related data, and they are providing the data in a laptop, and we are ensuring the 4G internet connectivity in the rural level. So, at total amount of total number of community clinic is more than 13,000, and the community healthcare providers are working to collect the service-related data. But we are found that the surrounding catchment area peoples of rural areas are seeking the primary healthcare services from the community clinic, but we cannot measure those services. The community where they live, and they are collecting the household informations, and they also input the health-related informations of this household, like who are the under 5 of this community, who are the pregnant women of this community. So they also motivated those under 5 children and the pregnant women to come to the community clinic and take healthcare services. So when when they input the informations from the community, we from our side, the community healthcare providers, they are ready to provide the healthcare services. So against the health household information, we provide the health card to the community. So after receiving the health card, when they come to the community clinics, they also take the health card, and the healthcare providers input the information, health-related information to the internet offline versions uh, in their apps. And the total systems is called PRIMA. It's like population registrations information management applications. So household informations are collected from the community, and service informations are collected from the community clinic. And in the measuring health outcome, we are analyzing the both of this data, that which populations are living in the community and who are taking services from the community clinic. So from analyzing this both database, we can find the area-based informations, that which disease are more likely to this area, or which mothers are risky pregnancy, mothers in risky pregnancy or not, which underfed children are more likely to have their many diseases like pneumonia or any other IMCA related disease. That we are providing the IMCA intervention, that is integrated management of childhood illness for the, and we also include the EPI systems, that who the children are taking the immunization facility from the community clinic and the other rural facilities. So we are also taking these types of informations. So it is in the first stage, we are collecting the household informations from the 9 sub-district level facilities, and all the community clinics and catchment areas are covering from the first stage. And then we are in the second stage, we are also expand this program in 34 sub-district level. So we are expanding this program up to the whole country, and with these measuring systems, we can assure that all the people have got the health services from the community clinics or not, and the policymaker can take their decisions that what to be done so to ensure their health seeking health services. So by these steps, we are providing the mHealth system, and we hope that this will give new innovations and new services to the digital health system.
Thank you so much, Mununapa. One thing I was really interested to know more about is how does all these like there are 15,000 CHCPs who are using the system, their different systems to report to the DGHS2, and how does this add to the overall automation of the systems, and how do you use this data to make informed decisions?
Thanks for these questions. It is really a good initiative that is also mentioned our Director General, Professor Azad sir, that all the healthcare providers are using their personal laptops, and which is provided from the management information systems of Directorial General Health Services, and they are also providing the internet connections. So we are focusing on underfed children's maternal information and adult information and adolescent information. So we are collecting the data in 3 forms of DHS2. So they are giving the data who are coming to the community clinic as aggregated format. And there are another system that is called individual tracker. They also track the individual mothers and individuals underfed children. Though there are some challenges in these systems, but this is a very informative and decision-making platform for the policymakers, because the Upazila or sub-district level managers can see or can make decisions that we have like 100 mothers in the community. So how to provide these mothers by the community healthcare providers, and they can identify the danger signs and they can refer to the higher centers. So this is totally initiatives and new initiatives, and also running in our country and from the rural areas. So it is also a milestone of in digital health system.
Thank you so much, Dr. Munmun. So the way Munmun Appa is explaining it is, it's not only the top level decision making, it's not only the very high level decisions that are being made from the information that are being collected. It's also on the ground operational decisions that are being made using this system, and everyone is getting the benefit out of it. So everyone is also willing to use this system in a much more efficient way. One of our attendant, or one of our participants have provided a question to us. We have got a question like, what is the current national budget for digital health in Bangladesh? So I would like to direct this question to our Dr. Be-Nazir Ahmed. So if you would like to provide an answer, sir.
Thank you. Thank you for the question. Actually, in Bangladesh, our health programs are managed through a sector-wide program. It is a 5 years actually program, and under these there are different operation plans. They actually work for individual component. So one of them is HIS and eHealth, Health Information System and eHealth. And for these 5 years, starting from 2017 to 2020, the total budget is $95 million. On average, you can say $19 million each year. So they have some actually objective. They work on improving the existing health information system through strengthening the population-based HIS, strengthening institutional-based HIS, strengthening human resource-related HIS, strengthening program-based HIS. So these sort of things actually are planned annually, and these are, as Alain mentioned, that actually if there is a costed plan, that is the great. And actually they have the costed action plan, not only for 1 year, actually it is for 5 years, but implemented annually, yearly. So thank you very much for the question. Thank you, Jackie.
Thank you. Another question that came to us is maybe anyone from here can actually take this question, that what is the experience using unique identifier in tracker? If you, so when you use the unique identifiers in the tracker, what kind of benefits do you get?
So thank you for these questions. So when unique ID is given to a patient or individual, when the patient comes for next visit, the patient first the time for the healthcare provider who have to take the individual's information, he or she need no need to take the information several times. So first, the time is important factors. Then the informations of risk factors, like the mother have risk factors previous pregnancy. So this can add it in next pregnancy informations, and she can identify the mothers very efficiently. So she can reminder and take initiative for the next pregnancy. And another thing is that the healthcare providers can take the proper decisions and proper counseling informations to the mothers. So individual health ID is also very informative and important for both the service providers and service seekers.
I can add a little on that. Actually, Bangladesh has been planning to use these unique ID for every individuals from birth to death actually. So we have been thinking over it, how we can use say for example, when a child is born, so we can provide an unique number which will be actually throughout his life, and whatever events in terms of health occurs, it will be recorded, and actually in decision making for his healthcare or her healthcare, it will be actually instrumental. So actually already in Bangladesh, there is national ID number, So there have been some actually discussion on how a comprehensive and unique number can be used for many things, so that can be really useful, so that people will not have many ID number, but one unique ID number, and that can be used for health also.
So, if that answers Alan's question, I'm sure that he has more to add. Before we go back to Dr. Alain Labrique, I would like to ask Dr. Rezaur Rahman Khan, Deputy Program Manager of Extended Program for Immunization, EPI. Sir, would you like to add something from your experience about the EPI trackers that you have been working on? How that came to be, and how are you like getting the benefit of these systems?
Thank you, Jackie. Good afternoon, everybody. Let me say something about the background of e-tracker. Bangladesh achieved fully vaccination coverage by 82%, but for years it varies from 80 to 85%. So there are significant coverage gaps between urban and rural, and in some geographical areas. There are gaps between valid and good coverage. Invalid doses, dropout, and left out are the main reasons for this coverage, low coverage. There are big differences between administrative and survey coverage also. So for fixing these gaps, we introduce immunization e-tracker for in some parts. Now it is in the piloting space. The objective of immunization e-tracker is introduction of an effective and reliable online registration system to monitor unvaccinated, partially vaccinated and fully vaccinated children. Registration of every child after birth in a catchment area, and fixation of accurate target children. That is the number 2. And number 3 is reminding next due dose of vaccine or dropout through SMS, so short message service system, to mother for timely vaccination and to reduce dropout. Number 4 is detection of all doses, all invalid doses through SMS alert and correction. E-tracker will automate the vaccinators' manual registration and prepare a list for children by date according to vaccinators' immunization session schedule. This is the objectives. Our main feature of EPI e-tracker is both Android. It is in both Android and web-based. Registration of children as per current manual registration element. Number 3 is vaccination record entry as per current EPI schedule. And number 4 is SMS alert. And number 5 is pop-up messages to vaccinator for invalid dose. SMS to supervisor and managers for invalid dose. And list of due doses and overdue doses. This is all about the major EPI e-tracker. And next, what about?
Okay, I can add a little bit actually. You know, Bangladesh has a large population, 167 million or like that. And so we have to actually immunize millions of children every year. And they have to give in a lot of antigens also, you know. I think in the API they have been using now 19 antigens, I think. 9 antigens, 11 antigens. So actually it is a huge data. Earlier they were entered into hard copy, and actually it was impossible to use those data from thousands of centers all over the country. But nowadays we have started to enter them electronically and bring them into DGHS2. You know, we have one of the best DGHS2 system in the world maybe. And actually we have a very robust system, and we have been using it also quite efficiently. So actually these data are now entered into the DHS2, and at the local level manager, like the sub-district level, they can actually auto-generate some local health bulletin where these data will be actually reported. And they have been using now when they're attending any workshop or training, that they can present their actually automated these local health bulletin. And regarding other aspects, LMIS, actually we have been trying to introduce. Already it is quite good in family planning. Now we want to use in other parts of health, like the EPI also, because we have to deal with huge logistics, vaccine, cold chain, carrier, and other things. That is impossible actually to monitor. But actually, we hope that in the coming days, we will have a very good LMIS in EPI also.
Thank you, both of you, for this expert opinion. We have been hearing a lot about all the interesting successes in Bangladesh, a lot of large-scale projects that are going on. I would like to ask our expert panelist, Dr. Shariful Haque Siddique, about why do you think that it is important to set up a unit to coordinate ICT initiative? And what kind of key challenges that you are facing while doing it? So you must have a lot of challenges. So what kind of challenges do you face like establishing this?
Thank you, Mr. Jackie. There's so many challenges in our health sectors, like the communicable diseases and the health hazards, about the public health hazards, like the water and public water and sanitation system, pure water system, and like the PI, the communicable diseases in our country, and non-communicable diseases also, the diabetes and pressure. This the challenges in our country for the health hazards. But we are the most crowded people in this country. We know we are challenges the things by the communicable diseases and community by the community clinics and the PI. And we have the challenges. We can ensure the challenges that we can face the challenges by our maximum support.
I think, sir, you can also add something
yes.
about the coordination.
Exactly. Actually, these coordinations are what actually Dr. Shariful Haque was mentioning about the health challenges in our country. And to address those, actually, the Director General of Health Services thought to have a coordination, support, and innovation center. And accordingly, he started to bring some people, like some talented guys in the health sector. And actually, we through website gave an ad that who are interested to attend these coordination and support center, having some expertise in ICT. And actually many people applied, and from them we actually selected around 12 people from our health system. So you see, it is not a parallel system, rather bringing these people from our own health system for sustainability. But actually any new idea, any new innovation faced a lot of challenges. So when this actually center was established, I actually was assigned the task to coordinate this center. But many actually directors and others didn't like this, because this coordination center was trying to make some coordination and sometimes actually advising to avoid duplication or working together. So, usually people attitude is to work on their own, and sometimes they don't like that. You need a collaboration and coordination. they don't want to go out from their box. They want to remain in their box. So actually these coordination centers, they try to bring the people together. So you see these rooms, and I think over 2.5 years, there are hundreds of meetings bringing people of different departments, development organizations and others to do this coordination. So actually we face challenges. Sometimes people didn't like, sometimes people didn't cooperate. We actually have a lot of interventions. Those are innovative ideas, and actually those could really contribute in improving the lacks in our health management system. But actually some people at the key position, sometimes they didn't like it. And so sometimes we couldn't actually succeed in implementing those innovations. But in spite of that, we achieved a lot. And actually, Professor Ajay, the Director General, as it is his own idea, so he provided support. And actually, many partners, I can refer about the Rohingya crisis, about 1 million people suddenly were actually forced to leave Myanmar, and they suddenly came to Bangladesh in 2017. And actually, we have to face a lot of challenges in dealing with their health services. And these coordination center from Dhaka, actually, they successfully coordinated all the health activities are in there. There are tens of organizations, tens of dozens of organizations, international organizations, UN organizations, local NGOs, and actually we successfully coordinated them to work coherently and actually together, so that we succeeded. You will be happy to hear that we provided 2 million doses of oral cholera vaccine, and in spite of actually lack of safe water supply, lack of sanitation, during the last 2.5 years, there is not a single outbreak of cholera among the Rohingya people. So it is a real success. And unfortunately, the Rohingya children were not vaccinated against diphtheria, and a huge outbreak of diphtheria occurred. And actually, we didn't anticipate that they were not vaccinated. But when the outbreak occurred, we successfully handled the outbreak, and it is now controlled. So I think, in spite of the challenges, SARS, actually in our Prime Minister's office also, there are some centers like that. The Access to Information Center, they also played some role, this sort of coordination, innovation and like that. We are also trying like that. Usual trend of people is not to accept new things, but in spite of that, we have to go forward what is needed for public health. And I think actually coordination support center like that at the different level, I mean the ministry level, directorate level, can really contribute in maximizing the utilization of resources. Say for example, many people try to introduce some ICT in health, but actually these were sometimes duplication, sometimes those are not of a standard, and sometimes they are not actually interoperable. So these coordination center, we try to actually make them understand that please come up with some good that will be interoperable, especially that can be used in our DGHS platform. And actually, we have been successful in some cases to coordinate those. I think from that point of view, though we face challenges, I think I have some two colleagues. They have been you can refer Dr. Rezaur Islam and Ms. Noshiba. They have been actually working on HRIS in health service. And actually, they have been facing a lot of challenges. And it happens also that people in the administration section, they are habituated on working on actually paper. But they have been trying to convert it into electronic system, and they have been successful. They faced a lot of challenges from there. Can you please shortly describe how we have been working on the HRAs in health? Can you please? Can the camera go there? Yes. Okay, please.
Thank you, Professor Be-Nazir Ahmed sir, for the question. Let me first introduce myself. I am Dr. B.M. Islam, working as a medical officer in Central HRIS system. So we are implementing the Central HRIS system for last 10 years, about 10 years, and today we are at the position that we are doing all the things for human resource management through one software, which is called the Central HRS of the DGHS. Actually, we use this software to track the human resources, to track the distribution of human resources throughout the countries, and to track the facilities, to monitor the facilities, and for the transfer, posting, promotion, and orders, for leave orders, everything we have been doing with the software. But initially, the software is not a complete one, but gradually we developed, we faced many challenges to implement the software, and gradually we developed newer modules to overcome the software. Initially, we have the server of less capacity, and gradually the server capacity has been increased, and now it is doing smoothly. And now we are under 4G coverage, so that every facilities within Bangladesh can use the software seamlessly. So thank you.
Now, Shiva, can you tell, actually share your experience? Now, Shiva Rahman, she is actually an IT expert, and she has been involved in not only just supporting the HIS, rather she is involved in capacity building of different areas, actually people of different sections, like the ministry, like our district, Upajala and others. So not only at the central level, we have that capacity. Now it is going to the division level and district level. Now, Shiva Rahman, can you please?
Thank you, sir. I'm Shiva Rahman, working as a consultant in Coalition Support Center, DGHS. Actually, I'm working in HRS last 4 years, and now in 4 years, Minister of Health and Family Welfare and DGHS, DG Health, and division level, and use this online system, and we have lots of plan to develop this software.
Thank you. I want to contribute, actually compliment a little that recently you will be very happy to know that we have been recruiting 5,000 physicians in a batch. Actually, we recruit them in batches, and actually 5,000 physicians. And we actually thought that we shall train them before placement in different parts of the country. But before placement, we thought that we shall provide them training, and 5,000 people is not a easy matter. So actually, we have been giving them training through online, and they are participating. Already, they have completed 5 modules or 4 modules.
6 modules.
6 modules have been completed, and out of 4,800 physicians, already over 4,000 have registered and have been participating, and they are actually they will be assessed also online. And another thing, we have over 100,000 healthcare providers throughout the country, and actually we have developed a system for online application for everything, that there will be no paper. Actually, Digi Health, our health system is gradually moving towards paperless system. We have introduced the EGP for the procurement, and actually it is helping for a transparent, actually more transparent procurement system. And also we have started the e-filing, that earlier we used to see that piles of files in the office of the Digi. Now there is almost no file, and even when he is in a car, he is actually approving a file. Even when he is in New York or Geneva, he is approving a file. So it is a almost on time, real-time system, that whenever a file is coming to him, he is approving or not approving it. So these, I think, do you want to add anything that we have been using?
Monitoring tool.
Monitoring, okay. We have developed one monitoring tool for our healthcare facilities, both human resources and equipment and other logistics also. Through this software, we actually can actually monitor and want to understand the stock out or any non-functioning or like that. So I think this is more or less about some part of Munmun, please. Dr. Munmun wants to add a little, please.
So there's another thing I want to mention, that there is a real-time monitoring system in the nutrition sector. So when the vitamin A campaign is going on, with the monitor, go to visit the point where the vitamin A capsule is given to the rural people or in slum area. So we are tracking this system or tracking this activity by offline version of app, which is real-time monitoring, and which can also take the location of the center. So we can take the and we can view from the head office that which centers are working good or not working good. So this is also very helpful for the policymakers or national levels program managers. So they can monitor the ongoing program, which is going to the all over the Bangladesh, and we can measure the utilization of the vitamin A capsule that they are providing to all the underfed children or under 1 year of children. So this is also a good initiative from nutrition and National Nutrition Services from Bangladesh. They are using the ICT or real-time monitoring system in a their decision making.
Thank you so much.
I think who are interested can go into our website, DGHS BD, and you can see our actually dashboard.
DGHS.gov.bd.
Yes, DGHS.gov.bd. So if you actually enter into this, you can have some idea what is the status of e-health in Bangladesh. So who are interested, you may please attend, or if you want, we can actually send you website again. Thank you.
So the way we will do it is we will put up all these resources and tools that we are talking about onto our website. And after you have done watching this webinar, you can still log into this website and get these tools or links from there. We have among ourselves Dr. Charles Chengo, President of Zambia Health Informatics Association from Zambia. He is an expert in telemedicine, e-health software, and EMR installation for clinics and big hospitals. I would like to go to Dr. Charles Chengo to talk about the challenges in different and also the policies in Zambia.
Thank you very much, everyone. You can hear me? Thank you for the invitation. It's a great honor. Thank you that I've been able to meet people like Professor Alain and other colleagues from Bangladesh. I think after those wonderful presentations, it's difficult to present. Anyway, my duty is to talk about mHealth in Africa. I think Africa is characterized, I think some of the things Professor Alain has already alluded to them. It's characterized by high disease burden, and against that, then limited resources. high disease burdens, you take, for instance, if you're talking of infant mortalities. In fact, infant mortality in Zambia, under 5 infant mortality is about 61. Angola, 67. In developed countries, it's in single digits. And then against that, you have limited resources, human and financial. If you talk about the doctor, for instance, doctor per 1,000 inhabitants of a country. San Marino, I believe, was the highest. They have about 47.3. Literally in San Marino, 1 in 20 people is a doctor. Zambia, that ratio is 0.12, which is more than 400 times less compared to San Marino. So in a healthcare delivery system, we can look, someone devised a model which is called the healthcare iron triangle. And the 3 sides of the triangle is the quality, cost, and access. If you improve access, invariably the quality goes down unless you spend more money. That's meaning the cost goes up. Access also can come in terms of increasing population. Developed countries, Africa included, unfortunately, their population increase are not matching with the economic growth of their countries. So those are the challenges. So what is, how can we improve the value for money? How can we get more value for money? Is e-health the solution? E-health was developed by 2003 that e-health is the single most important revolution in healthcare since the advent of modern medicine. And the World Health Organization also thinks that is true. E-health can help to improve. E-health has great potential to address some of the challenges faced by both developed and developing countries in accessible, cost-effective, and high-quality healthcare services. In Zambia, the healthcare sector is poorly funded. I think per capita funding in Zambia is about $64. If you look at the developed countries, for instance, Australia is about $4,700 per capita. UK is about $4,100. Zambia is a paltry $64 per capita. That's the funding. So there are a lot of challenges emanating from that. Fortunately, in terms of policies in e-health, I think there is goodwill from the government, and to this end, the first draft Information and Communication Technology Policy was launched in December in 2003 in Zambia, and it had a section on specifically on e-health. And even the current ruling party, the current government, the ruling party, the political party that's in ruling, in their manifesto, there's a part on e-health. If I can quote, on page 27, to equip all district and provincial hospitals with the necessary information and communication technology infrastructure in order to facilitate access to telemedicine. And Zambia has since released e-health strategies. Currently, we have the second e-health strategy. It's an elaborate document. It has a lot of areas, mHealth, electronic medical records, e-learning, a lot of areas have been included. Now, like Africa, Africa and maybe generally speaking, developing nations, how can we leverage mobile health? And how is mHealth maybe a bit peculiar compared to other technologies? I think because as has already been mentioned, access to mobile phones in developing nations is relatively easier compared to other technologies. In 2000, according to Oxfam, in 2000, there were about 700 million mobile phones worldwide. And the developing nations only accounted for about a quarter of that number, which is about 180 mobile phones. But just 9 years later, there were over 4 billion mobile phones, and the developing nations accounted for more than 3/4, which is about 3 billion mobile phones, from 180 to 3 billion in 9 years. And Africa accounted for the biggest growth according to this Oxfam report. If you take, for instance, in Zambia, the population of Zambia is about 17 million. Out of 17 million, we have 15.6 million mobile phones, and 10.2 million people with mobile phones have access to internet. And what's good about internet is that the quality of internet has improved over the years. For instance, in 2008, when I was doing my master's under the University of Edinburgh, they gave us a link to download the software Magic Draw. It was a 100 megabytes file. I couldn't download that. I went to the internet cafe. It was showing me it was going to take something like 7 to 8 hours to download. But now, with the current internet we have, 100 megabytes doesn't take even up to 5 minutes. Most of the time, I use my phone as the hotspot. This is an S8, it's 4G now. Just use it as a hotspot, and 100 megabytes takes maybe 2 minutes to download. Yet, 10 years ago, that was going to take like 7 hours, 8 hours. So there is a lot of potential for mobile health in Africa because it's relatively easy to own mobile phones in Africa. According to Globalization and Health, the total number of mHealth programs implemented in sub-Saharan Africa between 2006 and 2017 was 485. These are different mHealth programs that have been implemented in different countries, over 400, close to 500 in sub-Saharan Africa over a period of about 10 years. So basically, these are programs that mHealth programs that people think of once, just most of the time is troubleshoot specific problems. We have the results. For instance, there's a program called the Mwana. Mwana in our local languages means a baby or a child. This was they came up with this program, mHealth program, to hasten the results, HIV, DNA PCR results, HIV test results for infants, so that they could reach the intended recipients in time. Zambia being a country with limited resources, initially we had only 2 centers, the whole country, where they were doing DNA PCR. That's the first test that is done for the children when they're about 2 weeks. So it used to take a lot of time for the results to reach the intended recipients. So the initiative that was arrived at was to start mHealth to distribute these results, and the results are getting to the intended people much quickly. There are other initiatives also, for instance, in cervical cancer, disseminating information about cervical cancer. This program was launched by the First Lady, and on the first day of launch, over 600,000 SMS messages were sent to women. There are other programs also in malaria and so on and so forth. But despite mobile phones being relatively more accessible in Africa, there are still challenges with the mHealth. If you take, for instance, Zambia, the people living below the poverty datum line is about 73%. So there's disparity between rural and urban. Whilst the rural people, the people would need and benefit more such innovative programs, the poverty levels are too high in rural areas. And the other challenge is also illiteracy, high levels of illiteracy. And as these programs are being started by different players, NGOs, government in conjunction with NGOs, are these programs talking to each other? Professor Alain talked about standardization. I'm aware the World Health Organization came up with a protocol on the points, what the standards for an mHealth program. I think it's a 14-point protocol. But is everyone following of standardization? And then interoperability has been mentioned as well, and information governance. When I was trying to do some research on information governance, actually in Africa it's very weak or lacking. I think maybe South Africa is the only country that was doing something on. They have already done something by now. If you take, for instance, in the UK, they have 1998 Data Protection Act. America, they have HIPAA. But in Africa, when I was trying to Google about what information governance is in place, it's like it's not. There's nothing in place. So that poses a big challenge when you have all this information in the open. I think I would call it in the open. If you are using technology like mobile phones, there's a lot of data which can be abused. So information governance is something that is. I think I'll end there.
So thank you so much, Dr. Chengo. That was really enlightening, and the information that we got from Zambia, it is actually helping us determine what kind of challenges that we might that Africa might face in the coming years, that Bangladesh has been facing for a while, and have tried to come up with some solutions. Thank you so much, Dr. Labrique. I would also like to thank all the participants. Almost over 100 participants have joined and watched this webinar while we were on air, and we would like all of them to come back and visit this website again and again, because all these resources and tools would be there, and you can actually access it in this website. So I would like to ask Dr. Be-Nazir Ahmed to give a vote of thanks and conclude this session.
Thank you, Jackie. Actually, we are very happy and proud to be a part of this webinar. And I think actually we are becoming a global village. And actually, if one country helps another, it is actually on both sides a win-win situation. And we should do that. And we will actually in the future also provide to any support if you actually like to have. Bangladesh will always be happy either to visit here from other countries, or if you want, we can send some of our expertise who are there. And one example is that I want to mention that for sustainability and for continuity, actually these e-health should be with the government so that actually no one feels that they are deprived. On the other hand, the government should recognize all the partners, not only the government, but the non-government ones. And that actually will help to scale up, have quality e-health, and also improvement in health service, especially those are actually avoid of better service. So I think gender equity and other equity also. So thank you very much. We are ending here, but actually everything that were discussed today or presented, those will be in these link you are attending. And even you can actually ask question or put any comment if you want. Lastly, I thanks Professor Labrique. It was a pleasure to hear from you. And also I want to thank all the colleagues who are here, and also all the people who actually make this webinar a success. Thank you very much.
Goodbye, everyone.